Hi everyone, and welcome to our Journey of a Kidney Transplant event, and thank you all for coming along tonight. My name is Amy and I'm the manager at PKD Australia and your host for this webinar. There's about 200 people joining us, hopefully from lands far and wide, so that's really wonderful and we appreciate you doing that. As a mark of respect, I'd like to start with an acknowledgement of country with thanks to the Yagara and Turrbal peoples whose country I come to you from tonight. I also acknowledge that we have presenters joining us from the beautiful Gadigal country in the south. So in the spirit of reconciliation, Polycystic Kidney Disease Australia pays our deep respect to the past, present and future traditional custodians and elders of the lands, winds and waters where we all meet. And a special welcome to any First Nations people joining us tonight. And to our friends from Aotearoa, I'd like to say no may, and welcome to you. On that note, can each of you that are attending tonight, please drop a note in the chat to tell us where you're joining from. And I'll just go into telling you a little bit about Polycystic Kidney Disease Australia. So at PKD Australia, we all have a personal connection to polycystic kidney disease. PKD Australia, was established in 2014 to fund medical research to find a cure for PKD. For those amongst you who don't know much about PKD, and there may be quite a number of you, as this is a general topic on kidney transplantation, it's a genetic kidney disease. There are a couple of types of polycystic kidney disease. One affects babies, and this is a very sad occurrence if it occurs for you, where 1 in 3 babies don't survive the first 4 weeks of life. And the other type of PKD, which generally affects adults, where more than half of those people will require a kidney transplant by the time they're 60. It's the most common genetic kidney disease in the world, and this means if just one of your parents has the PKD gene, you will have a 50% chance of inheriting PKD. Currently, more than 25,000 people have PKD in Australia, and to give you some perspective, it is more common than cystic fibrosis. So tonight's about providing you all information and knowledge to support and empower you in whatever aspect of the transplant journey you are on, and that's our #1 priority, and includes all of you, whether you have PKD or not. We're very lucky to be joined by Dr. Steve Chadban, a transplant physician and nephrologist who heads the nephrology department at Sydney's RPA, or Royal Prince Alfred Hospital. And Steve also runs research teams and advises the Commonwealth Government on chronic kidney disease and transplantation. Jen Oldershaw and Dave Stein are kindly joining us to share their personal experiences as a PKD transplant recipient and a living donor, respectively, and we'll hear their amazing story a bit later. After that, we'll allow about 15 to 20 minutes for a Q&A, and thanks to those that have submitted their questions already. Any others we get along throughout the presentation, we will get answered by our presenters later, along with the previously received ones, and Mel from PKD Australia will lead us in the Q&A, and I'll come back at the end to wrap things up. So over to you, Steve, and while Steve's getting ready to share his screen with us, I have a poll question that I'd love you to answer tonight, and I'll just pop that up on your screen shortly. Over to you, Steve.
Amy, thanks very much. And for that lovely introduction, and thanks very much to PKD Australia for inviting me along to talk about what I think is a really important topic and one that's dear to my heart. As you can see from this photograph, I'm coming to you from Gadigal country. I also wanted to show this photo because it's in some ways symbolic of what a transplant's all about. It's a great thing to aspire to. It enhances our life, but just like a harbour bridge, it requires a whole lot of service and a whole lot of work to get there, as did the Opera House. So against that background, I'd like to talk a little bit about the pathway to transplantation. For some background, we capture the number of people who have kidney failure requiring kidney replacement treatment in Australia. We display that all of you can access through the ANZ data website. And here in the cartoon, I've used the example of 2020 data, which showed that at that stage we had 12,815 people living with a kidney transplant that was supporting their life. In addition, we had 13,931 people who were alive by virtue of dialysis, giving us a total population between us across Australia of 26,000. If we add New Zealand to that, we're talking about over 30,000 people dependent on kidney replacement therapy. It's not a static pool, and the numbers on the left show you 3,000 people join the pool new to dialysis every year, and a little higher than that, 114 in that year were lucky enough to start with a preemptive kidney transplant. Both of these pathways are open to people with polycystic kidney disease. During the year, 990 patients transitioned from dialysis over to transplant by receiving either a kidney from a living donor or more commonly from a deceased donor. If you look at the right-hand side in the outputs of this cartoon, you can see that in the transplant population, 240 people died during that year, or 1.9 per 100 patient years. By comparison, on dialysis, 1,869 people lost their life at a rate of 13 per 100 patient years. This gives you a good idea of the main reason we wish to offer people transplants rather than dialysis. These numbers are not directly comparable, but what you can see is that a death rate of 13 per 100 patient years is far worse than 1.9. Now, if you have a kidney transplant, there's a second pathway that can lead to transplant failure, and that's if you remain alive but lose the function of your kidney transplant. And in 2020, 266 patients lost their kidney function but remained alive and returned to dialysis. If we step forward to 2022, which is the most recent data we have, the numbers are fairly similar but larger. We see that dialysis and transplant numbers grow by 3 or 4% every year, year on year. What also happened was that we had COVID in the middle, and so our transplant rates, as you'll see a little later in the talk, have dropped off a little bit due to COVID, but we're working hard to restore those rates. To give you a feel for the number and the age of kidney transplant recipients in Australia, the graph on the left-hand shows you the year across the x-axis, and as you can see, as the years went by, we did more and more kidney transplants from deceased donors up until 2019 when COVID hit, and the numbers dropped off by about 30%. I hope that 22 and 23 will see an upkick in those numbers. Throughout this period of time, living donor rates have remained pretty stable at around about a third of the number of transplants that we see from deceased donors. If you look at the graph on the right-hand side, you can see the spectrum of ages of our kidney recipients over this period of time. What it shows is the number of transplants per 100 dialysis years in this age group. So if you like here, if you're age 0 to 4, for every 100 little 0 to 4-year-olds who are on dialysis, 13.7 of them received a kidney transplant. Among those 5 to 14, you can see that 35% of people received a kidney transplant in that year, and the numbers then tail off pretty rapidly. What's interesting is the most common age group of people who transplant are 55 to 64, and there you can see that only 6.3% of those patients received a kidney transplant during the year. Why do we do so few kidney transplants? Because we just don't have enough donated kidneys. And it's not Australia that is exclusively faced by this challenge. This is some data that one of my postdoc students, Sarah White, accumulated around 10 years ago now, where Sarah said, what is the total global population of people receiving dialysis? And at that stage, it was 2.1 million. It's probably closer to 4 million now. She then used data sources to determine how many were on a kidney transplant waiting list, and they are shown in the blue rectangle. And I should point out here that every little kidney represents 10,000 patients. The orange kidneys, as you guessed, represent those who are lucky enough to receive a kidney transplant. And as you can see, that was only 76,000, or 3.5% of the world's dialysis population. This is a major problem for all of us. In Australia, however, once you're lucky enough to get a kidney transplant, your outlook has been improving era after era. When transplant began back in the mid-60s, 60% of our patients only survived through the first year, and of those, only 20% had a kidney transplant that worked at the end of 1 year. Pretty lousy outcomes. But as we accumulated more and more drugs and learned how to use them more effectively, you can see that through the 70s, 90% of patients were now surviving the first year, and 60% of those had a functioning transplant at the end of it. During the 2000s and in our current era, we're looking at 98% of our recipients are alive at the end of the first year, and at least 95% of them have a functioning kidney transplant free from dialysis. So outcomes continue to get better. But it's not just the drugs and the medical care that make that difference. It's also the type of donor. Now, I apologize that this slide looks a little bit complex. There are 4 graphs here. On the left-hand side, we're looking at patient survival after transplant. On the right-hand side, we're looking at kidney survival after transplant. The top panels with the green text look at people who received a kidney from a deceased donor. The bottom panels with the blue text show those who received a kidney from a living donor. What you can see here is that both in terms of the proportion of patients that survive, 90% versus 96% 5 years after the transplant, and the proportion of those people transplanted who are alive with a functioning kidney 5 years after transplant, 83% for deceased donor recipients, 90% for those who received a living kidney donor. You can see that if you're a recipient, you choose a living donor kidney any day, if you're lucky enough to have access to someone who is healthy enough and willing to donate you a kidney. As I mentioned, once people receive a kidney in Australia, the outlook is pretty good. And what you can see here in the left-hand panel from Anstarter are the numbers of people who are alive with a kidney transplant this number of years after kidney transplantation. And what you can see here is that there are approaching 300 people in this country who are more than 32 years after receiving their first kidney transplant. They're still alive with a functioning kidney. What you can see is that the majority of those are shown in green, meaning that they received a kidney from a deceased donor, and a smaller proportion from a living donor. This is largely because living donor numbers really only grew in any substantial way around about 20 years ago. So you can see that the proportion that's blue in the early years coming through is going to grow over time. Now, why do we see transplant failures? And that's shown fairly simplistically in the graph on the right-hand side, which shows the causes of transplant failure over time. What you can see here is that there are 2 dominant causes that continually increase over the years. The first of those is dying with a functioning kidney transplant. The major causes of that are just like the causes in the general population. Cardiovascular disease, heart attacks and strokes, number 1. And number 2 is cancer, and number 3 is infection. Just below that, the red line you can see is chronic damage to the kidney transplant over the years that we call chronic rejection. The other lines that stay pretty flat and don't really grow very much over time include all of the other things we worry about, like surgical complications, like acute rejection, and like the original disease coming back. For people with polycystic kidney disease, the original disease won't come back, which is good news. So how do we prevent transplant failure? Our main strategy here is to use immunosuppression, but just enough immunosuppression to keep our patients as healthy as possible without experiencing acute rejection. The graph at the top here shows time along the x-axis. And what happened here in red, it shows the risk of acute rejection, which is very high early and drops pretty much over the first 3 to 6 months over transplant, but remains at a low level risk for the rest of the life of that transplant. If we stop immunosuppression in the kidney recipient at any time after their transplant, usually acute rejection will occur and cause the transplant to fail. In the blue line, I've shown what we do with our immunosuppression doses, and Jen will be able to tell you in a couple of minutes just what that feels like to get a lot of immunosuppression early after the transplant. We then reduce it as the risk of acute rejection drops off, and we progressively reduce it over time, but we never eliminate that. And the reason is that the risks of chronic rejection, shown in green, progressively increase in time. We think that immunosuppression plays a role in reducing the risk of chronic rejection, but there are lots of other things that contribute, like high blood pressure, diabetes, and simply aging and wear and tear on the transplant that we can't fix with immunosuppression. Our immunosuppression after a transplant typically consists of some drugs in the vein at the time of transplant, like basiliximab, followed by 3 tablets or 3 different types of tablets, particularly steroids, mycophenolate, and tacrolimus, that we use at pretty heavy doses initially and then reduce the doses over time, so that the majority of Australian kidney transplant recipients receive 3 drugs to suppress their immune system's function for the rest of their life. Now we know that these 3 drugs cause predictable side effects. So in addition to these 3 drugs, we administer additional drugs to try and counter the side effects of these medications. And they may include blood pressure lowering drugs, drugs to protect bones from the effects of steroids, anti-diabetic agents, and antibiotics to prevent infections that we know occur at increased frequency after a transplant. Our audience tonight is dominated by people interested in polycystic kidney disease. And as you can see here, again from the ANSTATA registry, the underline in red shows the proportion of people with polycystic kidney disease who start to receive kidney replacement therapy, either dialysis or transplant, per year from 2018 through 2021. And you can see here that it's 5 to 7% of everybody starting kidney replacement treatment in Australia does so because of polycystic disease. So it's a significant minority. When we think of the path to transplantation and beyond, people with polycystic kidney disease face some specific challenges. And just put simplistically, I've divided that here into the phases of chronic kidney disease, preemptive transplantation, meaning transplant before dialysis for those lucky enough to have a living donor, the dialysis phase, and then a transplant phase. When we think of those separately, during CKD, most people with CKD in Australia and indeed worldwide will die with CKD most commonly from a heart attack or a stroke, rather than ever needing to receive dialysis or transplantation. So to give you a feel for that, we estimate that something like 1.5 million Australians have chronic kidney disease. However, as I've shown you, only 3,000 per year or thereabouts start kidney replacement therapy. The polycystic kidney disease, it's different. Most people with polycystic kidney disease are likely to progress to needing kidney replacement therapy. And I think the figure Amy gave you of around 50% by age 60 is about right. The other PKD specific factors are, as we see new polycystic kidney disease specific medications coming into the market, the potential to slow the rate of progression of kidney functional loss and potentially reduce the risks of needing transplant or dialysis are emerging over time. Other factors to consider are that people with polycystic kidney disease are at higher risk of infections in their cyst, in their kidney, or sometimes liver. and very slight but increased risks of berry aneurysms causing risk of stroke. So these are some additional factors that people with polycystic kidney disease need to navigate. Should kidney function decline to the point where preemptive transplantation is considered, we would consider this at any time below an eGFR of 20 mils per minute, but most commonly around about 10. This avoids the need for dialysis, which is terrific because we don't need to do surgery to create access for hemodialysis or peritoneal dialysis, but it does require a living donor who is fit enough to donate a kidney, who is willing to undergo the surgery and proceed with living donor transplantation. There are some specific issues to address if you have polycystic kidney disease. Principally, is there enough space in my tummy for a new kidney alongside of my two polycystic kidneys and or other organs such as liver or occasionally spleen or pancreas that may be larger than normal due to cysts? And decisions about having to remove one of these kidneys prior to a transplant are very large because inevitably if we remove one kidney, we halve whatever kidney function we will have. And it's a major operation that takes several weeks to recover from. So sometimes we try a preemptive transplant, but try to remove a kidney first and need to give the recipient dialysis for 6 weeks while they recover before we can move to living donor transplant. The next phase is dialysis for people who don't have access to a preemptive living donor transplant. Here patients need to consider hemodialysis versus peritoneal dialysis, and if so, what sort of dialysis access surgery they will have. For peritoneal dialysis, it's a Temcoff catheter placed in their tummy 2 weeks before starting dialysis. For hemodialysis, it's either a plastic catheter inserted in their chest, which can be used immediately, or much better, a fistula made in their arm several months ahead. A further decision needs to be made about home dialysis versus hospital. Home provides much greater autonomy and usually better dialysis and better outcomes, whereas hospital-based dialysis incurs a whole lot of travel and being in and out of hospitals for prolonged hours. Once a patient commences dialysis in Australia, they are entitled to be placed on a transplant waitlist once they've been assessed by a local transplant team and deemed suitable for transplant. There are again specifics to PKD. I mentioned, is there space for a kidney transplant? So that remains if someone is going to be listed for deceased donor kidney transplantation, do they need a kidney out to make space ahead of time? The additional considerations are, have their kidneys been chronically infected? Are there stones present that need removal prior to a transplant? People with PKD in several studies have been shown to be at higher risk of diabetes after a transplant. And if we are thinking of living kidney donation, which should always be on the table, what are the genetics here and how is this going to affect other siblings in the family who may also be at risk of polycystic kidney disease? The fourth phase then is transplantation. In any person proceeding to transplant, there are surgical risks, there are risks of rejection, metabolic complications like diabetes and osteoporosis. Psychologically, transplant is a challenging process, moving from dialysis to receiving an organ, a whole lot more drugs that may affect your psychology, and complexities along the way, such as rejection and hospital episodes. And then finally, rehab on the way back to hopefully restoring a productive, meaningful life in which life participation is enhanced. Again, with polycystic kidney disease, recipients, there are specifics. We do see more diabetes post-transplant. Liver or kidney cysts typically shrink after transplant from a kidney perspective, but liver ones sometimes enlarge, sometimes to the point where they can cause malnourishment or actually embarrassment of the tummy filling, requiring a liver transplant after kidney transplant. Thankfully, that's a very rare occurrence. Some drugs, such as sirolimus and everolimus, may actually accelerate shrinkage of kidney cysts and make more space in your tummy. Again, psychological challenges after transplant are significant, particularly if there's a living donor involved or if there are other family members who require transplant. infections of the cystic structures are at risk. And then finally, pregnancy presents additional risks, and particularly the choice about genetics and assessment of fetal disease or not. Against that background, I would like to promote transplantation as the best form of kidney replacement treatment, despite its challenges, with the best outcomes in terms of both length of life and quality of life. And I think that Jen will talk to you about that in a couple of minutes in very strong terms. For those of you who are contemplating a deceased donor kidney transplant, I would urge you to consider to attend all of your hospital's educational activities, and indeed for living donor recipients as well. And also to think through about what different donors provide. What we are seeing is that we have an increase in the number of increased risk donors, either because the donor may have had a blood-borne infection, particularly hepatitis C. The donor may have had a tumour, particularly brain cancers that don't spread to other organs. A donor may be what we call extended criteria because they're older or had high blood pressure or sometimes diabetes, or because they had some kidney injury at the time of transplant. At the hospital education sessions, we'll teach you about these donors, but also urge you to consider those along with your doctor, because the main message that we're seeing now is that the most important thing when being on the transplant waiting list is to get an offer and accept it and move forward with that transplant. And what we're seeing is that many of the donors from these types of contexts are producing some of the best kidneys we see. I can talk to that later if people are interested. There are several metrics that we can use that predict survival according to donor quality or indeed recipient quality, but what these two complex graphs show you here is that at the end of the day, there's not an awful lot of difference between the very best kidneys, as shown in dark blue here, and the 20% worst kidneys shown in the grey line here by 12 years after transplant. Bottom line is, if you're offered a kidney, we should be accepting them wherever possible. So I'd like to close now by summarising that PKD is a common cause of kidney failure treated with dialysis and or transplantation in Australia and New Zealand. I'd like to note that both dialysis and transplant are treatments. Neither are a cure for kidney failure. They're treatments. Polycystic kidney disease patients face specific challenges related to their native kidney disease and or other organ cysts. We often face questions about whether extra surgery is required to remove an organ to make room. Patients face the question of, if I have a kidney out to make room, will I need dialysis before a transplant, particularly if I have a living donor? And after transplant, what will happen to these other remaining cystic organs? I'd like to note that transplantation always entails risks of complications, but on average provides better length and quality of life for recipients and for their carers. And then finally, all kidneys are not equal. Living donors typically produce superior outcomes long-term, but many of our best recipients received deceased donors and do superbly in the longer term. The key message is get a transplant as soon as you can and take that offer. At that stage, Amy, I think I'd like to close and hand over to Jen, and then we can take questions later on.
Thanks, Steve. That was great. Yes, and we certainly will move on to that. So, Jen and Dave, if you'd like to take over now and tell us your story.
Sure. It was so interesting hearing all that. Even when you're in the middle of it, you still learn more new information about it. Hi, everybody. My name's Jen. This is my husband, Dave.
Hello.
Dave was my donor about 18 months ago as a living donor. I inherited PKD from my mum, who went through dialysis, both peritoneal and hemodialysis, and she got a kidney transplant at about the same age that I did. And her kidney lasted for about 10 years. Got my fingers crossed that Dave's will last a bit longer than that. But we knew this was coming for a long time, and I'm sure anyone with PKD knows that it's kind of a, it's like a storm in the distance, and you know that it's coming and it's going to hit at some point. And so we knew We'd had lots of conversations around what we would do. In my particular circumstance, because I'd seen my mum go through dialysis and the impact that it had on her and had on our family, that I was adamant that I wouldn't go on dialysis, which I guess wasn't always my choice, but I certainly made that clear when I was speaking to the doctors that I was trying to avoid dialysis as much as possible. We have a young daughter. She's only 11 now. She has, she's kind of seen her mum get a bit slower and a bit sicker as the impact of the PKD became more pronounced towards the end. So we talked about a transplant, a preemptive transplant very early in the piece, and Dave went through the workup for it, which took about a year. In our situation, my kidneys were very large, and it was interesting hearing Steve talk about that because I had both of my kidneys taken out. Mine were large, and it was a very live conversation that we had with the doctors at RPA and the surgeons about whether that would be the best way forward. I was, again, not very keen on the 6-week on dialysis. And the risks were explained very clearly to me about that would be a very major surgery, and it was. It was probably more grueling than I expected, but it was worth it for us because we were able to kind of shorten the period in which we were in the hospital system and recovering and in and out. So that was how we chose to do it. I also got the lucky dip, so I got the aneurysm and the Sydney kidney and the liver cyst as well. So I got the whole box and dice, which to this point are really not having a massive impact on me. I mean, again, it's a lot of monitoring and a lot of just keeping an eye on things. But we had the transplant. Oh, I should say that I had the transplant. I should say that that Dave in the workup was an okay match, but not a great match. And so the team at RPA suggested that we go into the kidney exchange, which we completely welcomed. We wanted to get the best kidney for us as possible, and also thought that there was a benefit in Dave offering the best kidney for somebody else. I still kind of feel like it was Dave's donation that got us here, even though it's somebody else's kidney that I carry around with me, and I'm very thankful for their involvement in the chain as well. We had our operations in a window of COVID, one of those windows between the COVID waves just before Christmas, December 21. And it was grueling, and the operation was big, but we got through the other side of it, and it's been not without its speed bumps along the way. And I think that was one of the things that the doctor said, that it won't be plain sailing the whole way. There'll be times when, there'll be moments where you're back in, or drugs aren't working quite right, or that there's things that, that need to be checked upon. And so knowing that that was going to be the case, I was kind of prepared for that. And it's been that way. It took a long time to get my drugs exactly right. And I think, Steve, you were involved in finally landing on the right drug regimen for me, which has been really terrific since. And I feel really good. And so that's kind of my side of the story. But Dave?
Yeah. When we kind of found out that, well, we've always known about Jen's condition because it's hereditary, and, so when we knew it was getting closer and numbers were starting to fall, I started thinking about my preparation and what I would do towards that. And it was to do with exercising. And I knew at some point, like I'm 51 now, I knew at some point I had to get off my ass and do something. And, because old age is coming. So it was a real turning point for me to get my body in shape and be in the best possible conditions so I could be the best donor for Jen. I like the idea of my kidney being inside Jen, but it wasn't going to be the best match, and that didn't happen. But I still, that was an adjustment as well, to think about my kidneys going to somebody else and what it does for that family as well. And Jen got hers from someone else. So we landed on that, and we were quite okay with that. That's part of the process. And this is the other thing I would say is all the medical staff and the people of RPA, the best in their fields. I felt really comfortable. We asked lots of questions, and if I was to give any kind of tips, I would say be active by asking questions. Also listen, like Steve's presentation there, it's full of graphs and figures and all these things, but it also points you to what the human story is about transplant and what the numbers are and what the survival rates are. And coming out of the back at now, I sort of look back on it 18 months later, and it's like, what the hell was that about? Like, what have we just been through? And life has continued on. I feel completely normal. I still ride my bike and do exercise. I do like 20 Ks a day and do somewhere between 60 and 100 kilometers on a bike. And my kind of chosen fitness regime was riding bikes, and that kind of, I just got right into that in the process. So yeah.
But it is a journey. It's interesting that this session is called The Journey of a Kidney Transplant, because it is, it comes at you, it takes a long time to come to you. And then I likened it to a colleague the other day. It's like a storm. You see, you're on kind of calm seas, and then you can see the storm on the horizon, and then at some point you kind of bang in the middle of it, and it is just absolute hellfire in there. And then it clears, and then life is relatively normal for us. I mean, I think I was going to struggle with the amount of drugs. And initially that was hard because, as Steve mentioned, there's side effects to those, which, I hadn't been taking really drugs before that. And so there were some side effects, and you wonder, is this how it's going to be forever? But it's amazing what time gives you. Like, we're 18 months out now, and life feels pretty normal. I'll get an alarm in about an hour's time to take my drugs, and that's pretty much the impact that it has on my life at the moment. Making sure that I've. But
the timing of it, like we found out it was like we signed up to the kidney exchange, and 2 weeks it took to get a match, and it was like, oh shit, this is happening now, and that was really great because it sort of came and went, and the recovery started, and I was about 6 weeks in recovery. Jen was about double that. But as I was recovering, I was accompanying her up to the hospital, and then trying to help with her when I was still going through my recovery as well. So there was a few, it wasn't easy, but it was good to be out of the hospital, be at home. My sister looked after us, and just be home with my daughter and eating home cooked meals. So that to me was a turning point of that journey, and sort of on the road to recovery.
Support's really important. We arrange support well in advance, because of, we are a 3-person family, and if 2 people are out recovering from operation, someone's got to get April to school and, cook meals and all that kind of stuff. But yeah. That's our story. It's funny when this is a really long story for us. It's a really intense family kind of experience, but that's the nuts and bolts of it.
Thanks, Jen and Dave and Steve before that. And look, I think it's a great combination when you get the real story of the people living it, and combined with the expertise of someone like Steve, and you can bring that together. So I think the best way for us to sort of take things from here will be to hand over to Mel, who's going to read out our questions that might be directed at either you, Jen and Dave, or potentially Steve as well. We've got a number of questions already being asked, and I'm not sure that we've had too many pop up during the session, so that might be sort of good. But I have to say, the questions that we've had have been incredible, and so I'm really pleased that we'll have enough time to be able to answer these, that I think will allay people's concerns and really be helpful for everybody. So over to you, Mel. Thank you.
Thank you, Amy, and thank you, Jen and Dave, and of course, Steve. We have a lot of questions, and they all feel just as important as each other. So I'm going to try and get through them as quickly as we can. I'm going to start with, majority of the questions are all sort of pre-transplant as well. So we'll start there. Steve, you spoke a little bit earlier to preemptive renal transplant, and how, the big pros of that is that it avoids dialysis, but of course it needs a living donor. Are there any other pros and cons that you would consider in that preemptive transplant process?
I just think starting dialysis is a really tricky thing physically, and as Jen pointed out, mentally as well. Many people with polycystic kidney disease have vivid memories of a parent doing it really tough on dialysis, and I think if you can avoid that, it's a wonderful thing. From a societal point of view and from a medicine point of view, the best outcomes we ever see are for people who receive a preemptive kidney transplant. So I think a couple of strong reasons if you can.
Great, thanks, Steve. And another question, why can't the donor testing be started before that 20% threshold for EGFR?
Sure can. And quite a number of my patients are adamant and say, right, I've got to typically people who've got a Dave in the wings say, look, you know, when the time comes on for it, I'm up for it. And we can often initiate that testing at 25% or whatever works for the rate at which the potential recipient is losing kidney function. For some people, that's really slow. For others, it's faster.
Great, thank you. Dave just mentioned exercise and the role that cycling played for him in preparing for that transplant. How would you recommend potential donors prepare, I suppose, both mentally and physically for the donation?
Dave, do you want to take that one on me?
Yeah, for sure. I would say to add mentally, I would say do the thinking on it, have the discussion with family members, have some tough conversations. Like there's very few times in your life that you've got to be really honest like this, you know, like getting married, having children, they're probably some of the most honest times in your life. This was a very honest conversation, and you have to, like the person you're donating to, you have to like them. You have to want to donate to them. You have to, you know, and there's some very tough questions in there. Like I even thought about things like, say, Jen and I, you know, divorced or we fought or we separated, would I still be able to live with myself thinking that she has, or she was, you know, a beneficiary of my kidney? And I was like, yes, there's actually no problem. But they're the kind of tough questions you have to go through mentally. And, you know,
That's also, you have to kind of be aware it might not work. Then, you know, as Steve
Yeah.
mentioned, there's the risks. You know, if Dave made this incredible kind of, you know, generous gesture and then it didn't work, would he be comfortable with that? And, you know, as you said, there's some tough kind of,
well, there
conversations.
was one time the doctor said to me, and this is just before we went in, he said, I mean, within the week or so, he said, if this doesn't, if your kidney gets taken out and say something happens to Jen, your kidney will be taken off, and then Jen will be in line to get another one, but it mightn't happen right now. And we're sort of made aware of that situation as well. So it's just being prepared for everything and doing all the thinking. So then now I actually have no problem whatsoever. I mean, 12 months out, something might hit me in the future, but who knows? You know, you don't know these things. So mentally, that's kind of the thinking you have to do. Physically, I just made it a mission of mine to the bike riding was a really good thing, because I got out on the bike. I used Jen as my motivation and got myself fit. And, you know, I just started off easy because I'm not actually prone to doing exercise. I hate doing exercise. It hurts. But it just started with, you know, a walk around the block or a ride 2 kilometers. Then it went to 4 kilometers, and I just kept adding on and adding on and adding on until I was doing 20 kilometers a day, 60 Ks, and, you know, looking at the sites and everything. It was brilliant. So it actually became part of my routine. And I think that's really important as well.
It's amazing. And I think very inspiring as well, Dave. Thank you.
Now, can I commend Dave on that? We frequently see people say, yes, I'll lose weight, I'll get fit because I want to donate, and either they don't or they do, and the transplant happens, then people revert to previous behaviours and put on weight. But it's critical not to do that. It's critical to keep at it and to maintain it post-transplant, not just pre-transplant, number one. And number two, ideally, take Jen along for the ride. Make her exercise and keep her fit too.
I think also Jen reminding every now and then she'll say to me, what you did was a really special thing. And I think it's important to get that kind of, assurance from her, but it equally, I
just saw a question there too that someone asked about had the recipient how to mentally prepare. I think I had a lifetime to prepare for it. I saw my mum go through it, and it wasn't a shock to me. I knew it was coming for many, many years, and that I guess if you're going to get a condition with some kind of positive blessing in it, at least you're not surprised by this condition. You see it coming a long way. But and just in terms of me, I wanted to make sure that Dave was really comfortable with that decision. And, I kind of knew he was, and, I gave him outs, along the way that, are you sure? Do you want to do this? And once he was locked in, then we just kind of moved together. We moved forward together.
There was one other, there was one pivotal thing, and I think this sort of adds to it as well. Friend of ours, his wife got breast cancer. This is before COVID. And I had good friend of mine, I had conversations with him about that. And the overriding thing I got from him is the helplessness that he felt towards, she had an illness that he couldn't do anything about. In this situation, the thing I found empowering was I could be an active member. Instead of sitting on the sidelines and watching Jen go through this, I could actually help her. And that felt very empowering for me as the donor as well. So that was a good thing.
And we have had lots of questions tonight on mental health, specifically relating to this process. Is there any formal support through the post-transplant process for both recipients or donors?
Absolutely. Pretty much every transplant program in this country has a liaison psychiatrist and or a psychologist working with them who is specialised in dealing with transplantation. And I often tell my patients that they're a psychiatrist who's not here to look after crazy people, but he is here to help a normal person get through a major life medical event, both for donors and recipients. Yet by legislation, living donors do need to see a psychiatrist as well as part of their workup. And all of those units offer ongoing liaison psychiatry or psychology post-transplant for anyone that needs it. The catch is putting your hand up if you feel that things are slipping for you and psychologically things aren't going well. And we also advise partners to keep an eye out for those things, because you don't always have insight into your own mental health issues. So they're two sort of key take-home things that can help.
And Steve, I found that really important as well, because having somebody independent of Jen and family members to talk to as well about this, that was really key for me as well.
I think there's one element too that we haven't mentioned too, is that post-transplant you go into a clinic every day for a period of time, which is actually quite challenging, because it's early in the morning. You need to do it before you take your drugs in the morning so they can get the right reading. So getting up quite early in the morning when I was still recovering, I found grueling. But it did put me in front of the doctors and the clinical nurses there in the kidney ward every day. And so I didn't necessarily need to say a psychologist, but just the understanding and the empathy and the depth of knowledge that the doctors were showing every day. That made a difference. Sometimes just someone saying to you, oh God, you've had a really rough trot, haven't you? Just is enough, if for a doctor to, or a nurse or someone to acknowledge that you're having a rough time, you go, yeah, I'm having a rough time today. That also helps. Like the support that certainly for us at RPA, the support from the people in the hospital was just extraordinary. Everyone we came across was fantastic.
Steve, this might be one for you. Jen also mentioned briefly the risks for her and Dave in their situation. What are those major risks when we think about being a living donor?
Being a living donor, there are short-term risks and long-term risks. The short-term ones are that this is an operation and people can die from surgery, and the risks of that occurring are about 1 in 3,000. And there have been 2 living donor deaths in this country, but over many thousands of patients. And when we look at those risks, they were quite predictable, and the patients were counselled that they were at higher risk. As medical professionals, we have an independent kidney specialist look at all of our donors, plus a transplant surgeon, physician and nursing team and psychiatry team all weigh into the risks and try and advise people like Dave about what their risks are short term. We also take all the measures we can to prevent those. With any infection, there are risks of pain, of infections, but of things like DVT causing a blood clot onto the lungs that can be fatal. So those are some of the risks we see. In the longer term, the risks are less well qualified, and I'll tell you why. We have living donor data out to 40 years that suggests that living donors outlive most other people in the population, which is really reassuring for Dave to hear, I think. As we move into a more modern era, as clinicians, we're becoming more ready to accept people who are a bit overweight, who have got high blood pressure that's treated and controlled, who may have had kidney stones in the past, or who may have smoked cigarettes and given them up. And as we accept a riskier population, the risks longer term of developing things like heart attacks, high blood pressure, and reduced kidney function probably do grow. And the biggest of those, we worry about developing kidney failure in the donors. The risk is probably doubled by doing this operation. But it's a bit like buying a lottery ticket, in that if you buy one lottery ticket, you've got one chance of winning the lottery, and it's very small. If you buy 2 lottery tickets, you double your chance that you can win the lottery, but the chance of winning the lottery is still incredibly small. And that's a good way to think about the risk of developing kidney failure after donating a kidney.
Thanks, Steve. And you mentioned just then something like high blood pressure. Are there any other health conditions that would immediately exclude someone from being able to be a donor? Things like type 2 diabetes, rheumatic fever as a baby, and then secondary to that, is there an age cutoff?
Yeah, 3 great questions. Type 2 diabetes and type 1 diabetes do exclude you from being a kidney donor. And the reasons are that we know you have a condition that does cause kidney disease in at least a third of people who have it. And we believe that if you have 1 kidney, that will accelerate faster than if you had 2 kidneys. We've occasionally done it in people who've had type 2 diabetes, no medications, and they're over the age of 65 years as a donor and have good kidney function. That would be about the exceptional case. The second part of that was, I've forgotten. Now, beyond type 2 diabetes, what was the next one? Is there an age cutoff? And realistically, there isn't. We've accepted donors. 73 is my oldest donor. He lived to about 85, and I saw him every year thereafter. And he then passed away quite a content man at the age of 86, just above the Australian average, having had a stroke with completely normal kidney function.
Wow,
so we will look at donors on their merits. I have to tell you, I feel more comfortable taking a kidney from a 51-year-old man than I do from a 21-year-old man, because I want to be able to look at the patient and assure them that I believe they've got sufficient kidney function to live a normal life. I can do that better with Dave than I can with the 21-year-old.
And we did have someone specifically ask about rheumatic fever as a baby. Is that an issue?
If your heart valves are good and your kidney function is normal, no problem. There are lots of specific medical issues that will be thoroughly assessed by the workup teams.
I suppose mentioning workups, is it possible, we've had this just come through in the chat tonight, can multiple family members or multiple potential donors get that workup at the same time, or is it sort of one by one?
We do the minor tests on a number of people, not uncommonly. The more invasive tests, like sticking a needle in the groin to do an angiogram of the kidney, we would only do to 1 person at a time, because those procedures are invasive and involve risk and are very expensive. Yeah. But at the first phase, we'd often look at a couple of people and say, wow, who's best?
Makes a lot of sense. And do you have to have the same blood type as the recipient, or is there any prep if you do?
Yes and no. So you don't have to have the same blood group as a recipient, and that are in Australia, we've probably done about 400 or 500 ABO incompatible blood kidney transplants. That's between different blood groups. Everyone's a little different, and we would assess on their merits. Some of those where the recipient's got a lot of antibodies against the blood group, we would do like Jen and Dave did and go in and recommend a paired kidney exchange. But for others, we can take away antibodies from the recipient, but before transplant with a special column and proceed with transplant at a small increase in the risk of acute rejection only.
Right, thank you. I asked you before about any health conditions that would exclude a potential donor. Are there any health conditions that would cause issues for the recipient? We had specifically a question come in, a patient that also has a heart condition that causes pressure on the brain as well. So there's a lot of things going on. Do you look at that and think, you know, straight away there are a number of things that would mean a patient couldn't have a transplant, or is there a real case-by-case scenario?
It's a real case by case, but the main one is if a potential donor has cancer that we're not convinced has been cured, we wouldn't proceed, because that would entail risk of spreading cancer cells in the kidney into the recipient, who we then put on immune suppression, and that favours the growth, the rapid growth of cancer cells. So we do quite avoid that. The other key conditions are those where there's any evidence of kidney damage, we wouldn't proceed.
Thank you. I think just before you wrapped your section, you mentioned getting that common question about what happens to the kidneys, native kidneys if left in the body post-transplant. So what does happen to them? Do they shrink, dissolve? And in Australia, is there a reason that that isn't common practice when we know it's happening a lot overseas to remove those kidneys?
So as Jen will tell you, whipping a couple of kidneys out, especially if they weigh 5 kilograms, which is not uncommon in the context of polycystic kidney disease, is a very big operation. It entails a lot of blood loss. It entails a big cut and often a fair bit of bleeding and pain. So we'd like not to do it if we can spare that, if there is room to pop another kidney in, because the natural history of polycystic kidneys over time post-transplant is shrinkage. There are some medications we can use that are immunosuppressants that probably accelerate the shrinkage for most patients. Rarely we would have to go and take a kidney out after the transplant because it continues to grow, or because it gets a stone, or because it gets infected. But that's probably less than 1 in 20 patients with polycystic kidney disease.
For a potential kidney recipient, if they're living with kidney function under 20%, say their function's sitting around 15%, is that dangerous? And how long, I don't know if you can even answer this, how long in general could someone live like that before getting a transplant if a transplant wasn't available?
I've had patients go for up to 5 years at that level, but typically what's happened to their previous 25% will tell the clinicians and the patient how rapidly they're progressing. Many of our patients get down to an eGFR of 5 or 6 or 7 before the transplant actually occurs. The lower the eGFR, the higher the risk that if that patient were to have some acute insult like a gastro that made them very dry, or if they caught pneumonia or COVID, for example, the probability that they would get more sick than other people and that their kidneys would fail at that time becomes higher. And that's why we don't let it run down too low.
Okay. We have a couple more questions. I just wanted to check with you, Steve, that you're happy for us to try and smash through a few of them.
We can give brief answers, particularly if Jen and Dave are up for it.
Question that came through again tonight during the session is, are there any vaccinations that patients or donors need to be up to date with before a transplant? And does that change the success of the transplant?
Success, no. Risks, yes. So you should be adequately vaccinated. There's a host of things, including COVID, that we like people vaccinated before transplant. There's some things like chicken pox that we struggle to vaccinate post-transplant with. All of the transplant centres have that list of requirements.
And as a patient, aside from medical management with your nephrologist, are there any major health and lifestyle recommendations that you'd recommend to try and avoid that transplant? Should we be avoiding alcohol, the occasional glass of wine?
I certainly wouldn't stop people having the occasional glass of wine. We don't want people to become alcoholics, but living within guidelines on alcohol, ideally 2 drinks at most, and ideally a couple of days free from alcohol, is all fine by me.
And I think we're moving into these last couple of questions are all post-transplant. And I'll ask this from both a donor and a patient perspective. So first, from a donor, what does the expected recovery look like as a transplant? You know, everyone has busy lives they're hoping to get back to. Is there an average amount of time people should set aside to recover?
Dave, what do you think?
Well, 6 weeks to definitely recover from the operation and everything. But I'd say 8 weeks. I'd say 2 months, and but also there's a complication of Jen was going through. So that was an extra thing we had to think about, and sort of childcare and all those extra things. So I would say 8 weeks would be enough time. Jen?
Well, I think if you were a donor and you had a desk job, you could probably get back before 8 weeks. I think we talked about this the other. Yeah, I just went too long. We were talking about this the other day, and it's kind of like an appendix operation, really. I mean, I know that there's
Shut up.
But it's like it's one of those operations that it's a 6 week kind of turnaround. And you're okay,
I reckon I probably could have got back at say 4 weeks at a stretch, and I still would have been okay. But I reckon take the time. Take the time.
Others certainly do return to work at 2 weeks to a desk job. But then again, if you're used to throwing around bags of cement for your work, you definitely need the 6 weeks off.
Yeah. And as far as for me, it was I took 3 months off work, and I think it was 10 weeks for me, and that was with both kidneys out and the transplant. I mean, but and then I wasn't 100% at that point, but I had a desk job and I was happy to get back to work. But it does take a while to feel 100% normal, and I would say that there was the rest of that year was probably getting back to normal, getting my strength back. But certainly was able to go, and we went on a bike. We went on one of the rail trails that this time last year. So 8 months afterwards, we were on a rail trail. We went to Europe. We tried to go to Europe in October, but that didn't work out. But then we went this year in January. So yeah, life got back to normal pretty quickly, albeit at a slightly slower pace for a while.
Oh, and you mentioned, Jen, that initially you were going into the clinic every day. What did that first month look like for you?
The first month out of I was in hospital for 2.5 weeks, and that was pretty grueling, but brought it on myself, decided to get 2 kidneys out. The time going into the hospital, I reckon that was pretty hard too. Like I even Dave was pushing me in a wheelchair to get up to the clinic. I couldn't walk very far. I had to sit down every 20 feet, and then, slowly I would walk a bit further and I get to the lift, by myself. And so that was really, you could see the recovery happening every day. So that was one of the things I would say in terms of a recipient to mentally prepare for, that once you get out of hospital, there is still a lot of maintenance and a lot of kind of outpatient activity that you're in. A lot of it's waiting around too. That was one of the hard things. There's a lot of people there. There's a lot of people wanting attention on a clinic day, and you just need to wait your turn. And so some, in the hard, waiting room chairs, some of that could be pretty tough too. But as time went on, you got days off, and the more days you got off, the easier it became. So again, it's one of those things. It's you got to kind of take the time and kind of be patient with the process.
We've got one last question. There were several more, but we think they've all been covered off through the session. And this last question relates to travel. So if you are donating a kidney to someone interstate, either through the paired kidney exchange, do you need to travel? And if you do, how soon can you come back home or fly back home?
Through the paired kidney exchange, the kidneys travel, but the donors don't. That's different to some other countries, for example, Canada, where it's the reverse. And therefore, you're typically discharged from your local hospital 4 days after the donation, give or take a day.
Thank you, Steve. Thank you so much, Steve, and Jen and Dave. We're so, so grateful for your time tonight answering all of these questions. Amy, I will hand back to you.
Well, thank you so much, and thanks everyone for sticking around. I'm going to just wrap up with a couple of things that struck me, I think, from what we've heard tonight. Transplant is the best outcome. If you're offered a kidney, take it. That's a bit of a brutal sentence, but Steve said that loud and clear. From Jen and Dave's perspective, and from my own perspective as a living donor to my husband, so similar situation. It's a hell of a ride, but I'd do it all again tomorrow. And I'm sure Jen and Dave, yep, they're nodding. Yep, that's a good sign. The other thing that I thought was that has come out of this for me is that there's a lot of hope in the research that is happening now. And we've been talking about the realities of a transplant and the process, which is important because that's what the topic was. But I think behind that is a lot of people who are worried about their future. And some of the research that we are seeing coming through, Steve would be at the coalface of, and PKD Australia is getting information about, is quite amazing. And that covers PKD patients as well as CKD patients. So I think there's hope, and that research is amazing, and we'll do our best to bring that information to you because we know that makes a difference to the journey that you're on. So all the take-home messages were great. Thank you, Jen and Dave. Amazing story and really lovely of you to join us. Steve, I know you've been super busy, so I also appreciate, and I'm sure everybody does. We've had about 126 people with us tonight, and 114 are still here. So thank you very much, everyone, and I will say good night. So go well, and good night. Thank you.
Thanks, Amy.
See you guys.